Okay, now that we've seen V-tach, we're going to go into the next critical rhythm. That's one of your main critical rhythms there. That is in ACLS and all your protocols. V-fib is the next one. V-fib is just chaos. It's everywhere. It can be very big like that and ununiform, or small little squiggles. This is the only difference is this is fine V-fib, this is coarse V-fib. Doesn't matter, treatment's still the same. This one right here, they're not going to have a pulse with. It's just the heart's quivering, shaking around, it's dying. At this point right here, if you catch it early enough, you defibrillate them, they most of the time can go back into a good rhythm or something treatable. This is always treated with electricity. V-fib is always shocked. There's not drugs or anything for that. It's always going straight to defibrillation immediately with that, chest compressions, whatever be the case. The last one of the ventricular rhythms is torsades de pointes. Literally, it's French for spinning on a point is what that comes from. And that looks like it's just spinning. It goes up and down, bigger, bigger, smaller, and back down, and then bigger, bigger, bigger again. Basically, it's just up and down from small to big, back to small to big to small to big. That's just a form of multifocal ventricular tachycardia, and the treatment for this, mag sulfate. Usually that's always what you go to with that. Just a rapid push of mag that will cause that, because that comes from a magnesium deficiency is really the only time you'll see torsades on anything. But once again, like any other rhythm, always check for a pulse. They could have a pulse with torsades as well, but it's immediate treatment. You cannot perfuse with any ventricular rhythm. There is never going to be a ventricular rhythm that the patient is actually perfusing well with. Now, the heart blocks. We talked about the first degree. The first degree really is nothing. This is your regular, everything's going good right here. And then on your first degree, P wave's a little bit farther away. That's not really a problem. Don't need to treat it or anything. Then we go into second degree. You got two types of second degree. Second degree, you'll have the P wave, and it gets normal, 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 and then it just drops a beat. Normal, normal, back to normal. This is a second degree type 2 block. The type 1, which is referred to as a Winkenbach, it's a way that one's put is P, QRS, T. Now notice the P wave a little bit farther from the QRS. Now it's way farther away. Now we have a P wave, but we have no QRS after that. That's a Winkenbach. So you can remember it by longer, longer, longer drop. It's a Winkenbach. And then the major one that you're going to have to worry about, these two here are usually treated with pacemakers as well, but this one here is the one that becomes a problem. This is third degree. Third degree, you got the P wave doing its own thing, the QRS doing its own thing, and there's no correlation between the two. They're just out here doing their own thing. So you're only getting a rate of anywhere less than 40, but oftentimes it's less than that. I've had patients that I've picked up before, and they have had a ventricular rate of 6. The heart was really only beating 6 times a minute. The P wave was firing a lot, but the QRS was only coming through about 6 times, so their actual heart rate was 6. Once again, this is a serious critical rhythm, is the third degree, so that needs to be treated immediately, and the only real treatment for that is transcutaneous pacing, or if you're in the facility, they would go for immediate pacemaker at that point as well. One way that I had someone put it to me and I kind of liked that went pretty good for remembering it was like a bad relationship that you would see with these. Right here, everything's good, perfect. Let's say the husband is the P wave and the wife's the QRS. So everything's good, they're right together where they need to be. First degree heart block, we're getting a little bit of a problem. They're not together. So it's starting to become a problem there. Now we got it over here. Everything's good, everything's good, everything's good. Next thing you know, husband's home right here with the P-wave. Wife's not there. That's a problem. Things ain't going so good. But they make up and everything comes back. We're good again. They're home, they're there. Back, happens again. So the wife left again. You can see it that way. Then you see in a second degree type 2. They're together. Oh, they're growing apart some more there, and gone again. So you can see it that way. Now, when you get to the third degree, completely gone. They've divorced, separated, went their own way. They're going their own way. P-Wave's doing his own thing over here. QRS is doing hers over here. They're not related. You'll hear this referred to as a lot of times too as P's and Q's go marching through with no correlation between the two. That's basically all the basics of the EKG that you'll need to know. The most important ones to watch for: third degree, any ventricular rhythms that you see, VFib, VTAC, anything like that. Any new onset of AFib is always a problem as well. It needs to be notified to the provider as well. That patient's going to need to be put on blood thinners and a bunch of other things going forward. But overall for EKGs, that's the main gist of it. Now, the only other section you'll see really is you need to know how to look for a STEMI, how to see an EMI on an EKG. Normal EKG is going to be right here, this line right here. Let me redraw that. Let me make it a little better. Right here, this line where it's flat at, that's supposed to be your isoelectric line. That's the baseline. That's where everything should be at. That's where all the beats should originate and all that. So with a STEMI, what you're going to see is you're going to see your P-wave is going to look fine, QRS is going to look good, but right there, you're going to see that elevation right there in that ST segment. That shows that there's heart death occurring, that those ventricles are not repolarizing as well, because remember, the T wave is the repolarization of the heart cells. If that blood supply to that area of the heart's blocked off, if there's a clot there, then the sodium and potassium ain't getting in there, so the heart can't beat as well as like it should. It's taking longer to get there. It's taking longer to repolarize. There's death coming. It may initially start out by being just right here, ever so small. So it's very important with patients who are post-cardiac to keep an eye on that. If you can catch it right there before it gets up here into these, which when it gets up into here, it starts to look like tombstones, as it's referred to, that's when it's really bad for the patient. If it can be caught down here before it becomes a problem, this patient can go in and get restented or whatever may need to be done to get perfusion back before more heart death occurs and cause more problems later on, which can lead to ventricular hypertrophy or anything else. Too much cell death, the heart can't recover, patient may need an LVAD or whatever be the case later on. But the most important part is keeping an eye on that. And you may see it a lot of times as well in post-cardiac patients, to where you will see minor elevation in one lead. In one lead, it's usually not anything that needs to be concerned about. You need to see it in 3 or more consecutive leads. And I'll send a picture of where the leads are and how they are, where they actually translate to on a 12 lead to get them to be consecutive. It has to be consecutive in 3 or more leads before it's really considered a STEMI. And you may also see in these patients as well that you would be dealing with ST depression. The depression shows old cardiac injury. That's usually not a problem. Usually it's just showing anything that's old. Anything that's acute is elevation as well. One other thing you could see that can mimic a STEMI is hyperkalemia. If your patient's hyperkalemic, they will have very peaked, very broad T wave. Sometimes can mimic it. You may also see depression and flat T waves in patients that have low potassium, hypokalemic. So that could be another cause for it. That's why you always need to double check everything and find out a history before you jump to conclusions on anything, and always look at the chart and see what is the patient's normal. Some people's normal is a wonky, weird EKG.